going to begin. Good morning, everyone, and Yahweh. Before we begin our program, may I ask Ministry of Health and Human Services Chaplain Reverend Pewich John to please come forward and offer us the opening prayer.
Molimsi, kajengchar, chenchar gia, kami jibar kuba isi ni man meja mali jalbalap, morakan chargan chuan rani man kobar karjilok kami lo yajimur, rani kain karu yangin kami kuba ipendron, nganam pararto ardak, alpatata piku meja lan, wawin ko nganam tari naik, nang meja nin siti, ilo hailingkin, kajaram man, yenin, makta janam chino yenin ruch, nanakwa magirit kadang ni kami alang ko cep kalek. Inna mitchalok tojin charbal anro jakal ken menin ke mitchap kanan magach ilo menodum jich akam kanan pajar jinim kataikem riwa jangani kalla bewam udijam ajewa jaraidin ale benawagin malak ken pojin kubai penron ngalangeni riro menodum jich kajaraman himsi kajaraman halip takdirin malip lejerin menodum jiral kubatok koin chiwan yeno yamban menilang menogo kem kada jani albadada apply go ale menegin Manar mejerinam, imcujugun berinam. Kumolok, amen.
Thank you, Reverend Pewich. I'd like to give a warm welcome to each and every one of you participants here this beautiful morning. Honorable leaders, distinguished guests, ladies and gentlemen. My name is Jean Phillip. I'll be your MC today. Non-communicable diseases are leading causes of death and disability globally, especially here in the Republic of the Marshall Islands. Yesterday, we learned that NCD has a high burden in our society. Not only is it affecting our elderly population, but now it is affecting the more younger generation. In the year 2012, we were reminded yesterday that His Excellency then President Christopher Loyac declared a state of health emergency due to our state high prevalence of NCDs. Sadly, with our current situation, I feel we are still in a state of health emergency. But with the multi-collaboration and multi-sectoral from all around the world, I know we can help bridge the healthcare gap, plan, and action. I'd like to welcome again everyone to our 2023 Non-Communicable Disease Conference, Day 2. I'd now like to welcome our first speaker of the day, Dr. Holden Nana, who is from the Mental Health Clinic. He'll be sharing with us mental health care in the RMI.
Thank you, Dr. Chin. Good morning, everybody. It's a pleasure and honor to be here with a group of smart, knowledgeable, and important people for RMI. My name is Dr. Old, and I'm from the Human Services. I want to start with, in Dr. Frank's opening statement, he mentioned that 85% of NCD are undergoing treatment, but not controlled. Dr. Chin just mentioned that NCD is the leading cause of mortality and disability. Doctors and nurses, when we have someone uncontrolled, we ask if they're compliant with medication. We ask if they're watching their diet. We ask if they're physically active. If they say yes to all, then we just take the next step of increasing their doses. But what if I tell you that they are not sleeping at night? A person with major depression will not sleep, and that increases the blood sugar. person with anxiety has elevated blood pressure, elevated blood cholesterol, and we may not need to address the doses, but address their other problems that they have. So please join me the next 10 minutes. I'll try to talk to you a little about the mental health services we have for RMI. You cannot read this, but I'm sharing this as a data of last 20 years. First, it's autism, children with autism. In 2020, the prevalence of it is 1 child in 150 children is diagnosed with autism. As of 2020, there is 1 in 30. In the past 20 years, autism has increased by 5-folds worldwide. And so are other mental conditions that are necessary for us to understand when we're dealing with NCD. The WHO released their work plan, action plan to reduce the mortality from NCDs. They call it the 25 by 25, which means to reduce NCD mortality by 25% by 2025. 4 major NCDs mentioned by WHO: cardiovascular diseases, cancer, chronic lung diseases, and diabetes. 7 risk factors for NCD to tackle by 2025. Tobacco use, harmful use of alcohol. Anybody see a missing piece on the picture? WHO action plan. Mental health is not written anywhere here. But all the risk factors, plus these major NCDs, are complicated and directly connected with mental health. So if we are to seriously tackle NCD in RMI, we have to approach it differently. Put it in spelling in black and white how mental health is important in our tackle of our NCDs. Next. Because we know there is a bidirectional effect between mental health and physical health. We've heard presentations of people getting medications but not taking their meds. That can be easily resolved if we have better approach to them with education, cognitive behavioral talk with patients, and community awareness. So as much as we want to improve the physical health of our people with NCD, we have to increase our awareness and orientation to mental health as well. Next. So in general, this is the epidemiology of mental health. Globally, 1 in 4 persons will suffer a serious or severe mental health condition somewhere down the line. 1 in 4. In USA, currently, in the past 12 months, 1 in 5 people. But the most common mental health issues like anxiety disorders, 1 in 3 in 10 people, that's 30% prevalence, suffer from anxiety disorders. Next. I heard from a number of presentations that diabetes is the number 1, overwhelming the inpatients, the outpatients, the clinics. But they said 3 out of 5, that's more than half of those cases that we're dealing with, they also present with mental health symptoms. And if you have diabetes with major depression or anxiety, it's very unlikely you're going to control their blood sugar. And it's very unlikely that they're going to be compliant and motivated to take the medication. So it's important to have the mental health as a partner. Feel free to refer for education, for awareness, and for cognitive behavioral therapy from the program. An update on what the program has. The biggest is we have a YAG award. Please give a hand to the ministry. That's the first in the region with a crisis facility and a stress ward. And we have opened it in February of this year. Maximum of 4 beds for stress ward and 2 crisis facility units. For 2 years, we didn't have administrators, but now we have a program director and an administrator. We had an addition of second clinician. There's Dr. Autry at the back working with us. Hopefully, you'll also continue on with his post-grad studies. We still have 4 nurses, but the director is an addition. She's a nurse, and we're using her sometimes as another additional nurse. We're near completion of hiring 10 new mental health staff, which are community health workers, to be located in Laura and Achildage, which can also work side by side with the profiling team to assist on both sides. Just a snapshot of our monthly work. September last month, the Human Services will receive 15 new cases, registered cases, youngest being 4, eldest 68 years old. We had 6 self-referrals. 6 years ago, we did not get self-referrals. Everybody was pushed in by families and by police. But people are walking in now, so stigma is less. We only had 2 psychosis new cases and 6 emotional and mood diagnosis, which seems to be in line with the global picture. There's supposed to be less schizophrenia or less psychosis and more mood and emotional disorders around. The clinic has seen 9 outpatient cases in September and 23 cases from the neighboring islands, and we had no reported suicide case, whether completed or attempted. And this is what our program is currently doing. We have established the drug and alcohol policy for the ministry, which gives that responsibility to all supervisors to be able to not complain but to report and bring in staff that need it. Because Ministry of Health is a highly stressful workplace, yeah? And so some people use alcohol and drugs as medication. So in order for us to help them, we got to bring them in for other means of treatment for their stresses. The department also has created the urine and drug screening protocol. Now all ER cases are allowed to do toxicology for any emergency cases, MVA, ICU, and ER. There's a workplace mental health policy for the ministry, led by the Department of Human Services. If you or your department is not aware of the mental health wellness policy, please invite the HR or our department to come and elaborate on the policy to help you and your staff. We launched the GBV, Gender-Based Violence Standard Procedures, and that's been going well. There's a lot of progress. We have over 10 reported cases. Last month, we actually went to court with one of the cases of gender-based violence, child sexual case, and have a verdict of 25 years for the perpetrator. Public Health Safety and Welfare Act, there's an amendment. We work with AG's office and the ministry's administration. In the past, we had that human right where if somebody doesn't agree with treatment, we follow that. But now we can do involuntary treatment. If there is a clinical judgment that treatment is essential for life-saving purpose, then we do involuntary treatment, which is added to the Public Health Act. The program, although we don't have any operational funds, we secured CDC funding, which is now helping the program to do community mental health work for a while. We are now involved in doing mental status examinations and clearance for people that wanting to own firearm. For some employment, international employment requirements, as well as we do assessment for the parole board of Marshall Islands. This department also gets involved with the legal system as forensic psychiatry on behalf of many of the departments. So for any legal matters that your department may face, we can also assist on behalf for legal purposes. Moving forward, big work plans that we have in place, the department wishes to establish a school program for youth, a SMART club. We call it a Student Mental Awareness and Advocacy Resiliency Teens. Instead of us presenting to them once a year, we want to make the clubs available in all schools where they do their own activities, and we support them, give them the ownership of mental health learning and activities. Secondly, crisis intervention team. We have secured with SAMHSA nearly $500,000 for crisis team, which is the current priority for mental health worldwide. Once we get that fund, if we get that fund, we got to have a crisis team, because nurses and doctors and police are not supposed to be responding to crisis situations in the community. Sometimes when police respond, it only escalates the crisis, and we're putting our staff at risk when they're put in the front line like that. And we want to train crisis team to become part of our health services. It's essential that as part of NCT, we also create a primary mental health team to provide awareness and education to communities and schools on a regular basis. We're hoping to get more professional staff as well. We do not have counselors at the moment. We do not have therapists at the moment. But the small team is trying to do everything they're able to. But hopefully, we get more support staff for the department. And lastly, we're hoping and working with the leadership to regain our operational funds. The mental health operation is all under SAMHSA, and over nearly 3 years now, we are unable to access any of our operational funds. And we're hoping that with the leadership of the country, sooner we can get back the access to our federal grants. And that is my brief talk about mental health. Thank you.
Thank you, Dr. Holden, for reminding us mental health is a very important part of NCD. Our next speaker, I'd like to welcome Dr. Hoon Hin Chen from the Taipei Medical University, Shuanghu Hospital, to talk to us about child malnutrition.
Good morning, ladies and gentlemen. I'm Dr. Chen Hongyan from Shuanghe Hospital in Taiwan, pediatrician. Yagui. Today I'm glad to share the children's health care experience from Taiwan. today's outline. Next. First of all, I would like to talk about the pediatric preventive medicine clinic. Pediatric preventive medicine, also called the well baby clinic, is for well child visitor. Okay. The doctor will check the child's growth and development in order to find or prevent the problems. The children also will receive immunization during the visit. The pediatric clinic is for acute or chronic illness. We can avoid the transmission of infection by the design of a clinic. Next. It's in our hospital. The well baby clinic and the pediatric clinic both are located in the second floor in our medical building, but they are separated with a different entrance. This is the door of the well baby clinic. Okay, next. This is the patient flow chart in preventive medicine clinic. First, the staff register the patient. Then the nurse measure the child body weight, body height, and head circumference. Later, the pediatrician check the child's growth and development. Also, the child will receive immunization during the visit if the condition is stable. Next. Okay. Next, I talk about the child's health handbook. Next. Okay. In Taiwan, every child has a personalized health handbook after birth. In addition to Chinese version of a child's health handbook, there is also English version. It is the content of a children's health handbook. It includes the baby's health record, children growth curve, children chart, and health education information. It's including a newborn screen test, hearing screen test, records of the oral health and baby teeth care, and preventive vaccination information, and the information of resource, and the contact information of a child care. Okay. There's also health education information for the parents. Next. There's baby birth condition records in the health handbook. It's including the bone body weight, upper skull, and gestation of weeks. So the doctor can understand the baby's birth condition. Okay. Next. There's also useful health education information, such as neonatal care know-how. Okay. So the parents can get useful information from the handbook. Next. Okay. Okay, thank you. Next, I talk about newborn screen in Taiwan. Okay. The purpose of a newborn screen is to detect a congenital metabolic disorder. The blood sample is collected from the newborn's heels within 48 hours of birth. The sample is then sent to the authorized neonatal screening center for testing. About 2 weeks later, the parents can check the results on the website of the center. The newborn screen records also in the Children Health Handbook. Next. About 4 years ago, there were only 11 kinds of metabolic disorder in newborn screen sponsored by the government in Taiwan. Since October 2019, another 10 kinds of disease were added. So nowadays, there are 21 kinds of metabolic disease in newborn screen in Taiwan, sponsored by the government. Okay. Next. Okay. I will talk about the baby stool card. What is baby stool card? The mother can screen for the hepatobiliary disease by comparing the baby's stool card to the number of pictures in the handbook. Just in this picture, in the figures. Okay. We need to check the total and the direct bilirubin if the baby has a following situation. First, prolonged jaundice. The jaundice lasts for more than 14 days after birth. Or when baby's stool color appears abnormal, such as a pale stool. In this figure, number 1 to number 6 is abnormal. Okay. Next. Biliary atresia is one of the most common neonatal liver disease, especially in Asia, such as Japanese and Taiwanese. Okay. In this condition, the baby's bile ducts are obstructed, resulting in obstructive jaundice. The mother can screen for the disease by comparing the baby's stool color to the stool color card. Once the diagnosis is complete, cassette procedure should be performed within 6 days. The earlier, the better. Next. Next, I talk about the children preventive health care service in Taiwan. There are 7 types of children's preventive health care service in Taiwan from government subsidy. The suggested age is within 6 days old, 1 month old, 2 to 3 months old, 4 to 9 months old, 10 to 18 months old, 18 to 24 months old, 2 to 3 years, and 3 to 7 years old. The service item including physical examination, feeding status, and development diagnosis and observation. Okay. The table shows the service item details in each suggested group. Totally, there are 7 types of preventive health service till 7 years old, sponsored by the government. Okay. Next. The growth chart consists a series of percentile curves. The charts illustrate the distribution of select body measurement. We can use the chart to track the growth of children. Next. For children, BMI screen for potential weight and health-related issue. The normal BMI is between 50th percentile and the 8th percentile for the age and the gender. If the children have a low or high BMI for their age and gender, we should perform further assessment, such as family history-taking, eating pattern, or other medical problems, or even endocrine disease survey. Next. Development milestones are a set of function skill or age-specific tasks that most children can do at a certain age range. Before well baby clinic visit, the parents should check the milestone for their children. When the children older than the adult age are still not able to perform the respective activity, the parent should ask the doctor for the professional help. Next. After completing preventive health care services, there should be a check-up date and the hospital stamps in a medical certificate in the handbook. Okay. Next. I will talk about the vaccination. This table shows the time schedule of government-funded vaccine for children in Taiwan. Most has children receive at least 10 common vaccine, including HPV vaccine, BCG, pneumococcal, PCV13, and chickenpox vaccine, and so on. Okay, next. Okay. This is the table of records of vaccination in Children's Health Handbook. Okay. Next. Continue. This is also the table of records of vaccination. Okay. Next. Okay. I will talk about oral health and baby teeth care. From the eruption of the first tooth to the 1 year old, the baby can receive oral checkups and fluoride vaccination. The child can go to dentist every 6 months for fluoride vaccination. It's sponsored by the government. It should be checked and recorded by dentists in the health handbook. Okay. Next, I talk about the newborn hearing screen test. Okay. The newborn should receive a hearing screen test within 24 to 36 hours after birth. If the test failed, recheck within 36 to 60 hours. If failed again, refer to the ENT doctor within 1 month old. Once confirmed of the diagnosis of the hearing loss, the baby should receive early intervention within 6 months old. In Taiwan, infants younger than 3 months old can receive 1 free screen test. Okay. Congenital hearing loss should be diagnosed within 3 months old. Okay. For baby with hearing loss, hearing aid and hearing rehabilitation should be arranged within 6 months old. Okay. The young patient can so that the young patient can have a normal language development. This is my reference. Okay. Okay. Next. Thank you for your listening. Thank you very much. Okay.
Thank you, Dr. Chen. Dr. Chen is actually visiting from Taiwan. He's here helping us with our pediatric patients in the hospital. Komoltada. Our next speaker, I'd like to welcome her to the front from MOCIA, Child Health Director, Joy Kaminaga, to talk to us about children protection health in RMI. Apologies, she's not here right now, so we'll move on to our next speaker. Okay, at this moment, I'd like to welcome from Taipei Medical University, Shuanghu Hospital, Dr. Li Hao, to talk to us about Taiwan maternal health. Be joining us through the Zoom.
My name is Howard Lee, and I'm an OB/GYN doctor from Shuanghe Hospital. Next slide. Or should I? Okay. So I'm just going to talk very briefly about the future trends and also the challenges of maternal health in Taiwan. And then also very quickly give an overview of the prenatal care in Taiwan. Next slide. Next. Okay. So in Taiwan, we can see that the fertility rate is dropping, and since 1985, it's actually been below the replacement rate. So that's kind of how it's been for Taiwan for 2 decades now. Next. And we can also see that the average age of pregnancy in Taiwan is rising. And so for overall age, it passed 30 in around like 2010. And we're also talking about nullipara women. So nullipara woman, the average age. So the average age that a Taiwanese woman has her first kid is also past the age 30. And as we all know, geriatric pregnancy is over the age of 35. Next. Next. Okay, and if we look at pregnancies by age group, we can see that a third of the pregnancies are over the age of 35. So what this means is that with the increasing age of pregnancies, we get more of the, for example, high-risk pregnancies such as preeclampsia, GDM, or even chronic hypertension superimposed, or just type 1 or type 2 diabetes. Non-communicable diseases are increased in this age group, which complicates the pregnancies. All right, next. And so if we look at the maternal mortality rate in Taiwan per 100,000 live births, in Taiwan as of 2022, it's around 13. So for the past few years, it's been maintained around 13 to 14. And what's interesting here is we can see that in 2014, there's actually an increase in, 2016, there's an increase in maternal mortality. And this is actually because there was a paper in 2015 that showed that maternal mortality has actually been underreported for the years 2004 to 2011. And so the government started a maternal mortality and morbidity reporting system in 2016. And so I would say that the numbers from 2016 onwards is probably more accurate than the numbers before. And just to put this into perspective, so the maternal mortality rate in the USA in 2021, so this is from their CDC website, is 32.9. And Japan, the latest number I could find was in 2020, which is 4. So Taiwan is somewhere in between Japan and USA. All right, next. And if we look at neonatal mortality, it's slowly decreasing, not at a very rapid rate, but it is quite low. So as of 2022, it's 2.8 per 1,000 live births. Next. And when we talk about maternal health care, we also want to look at the cesarean section rate. So cesarean section rate in Taiwan has been pretty stable at around just a bit over 35%. Now, obviously, this is not the WHO recommended. It's actually quite a bit higher. And the government has been trying to control this. But I think just depending on the kind of the culture and also the how the healthcare system is set up, the cesarean section rate can be tailored to each country. But at least for Taiwan, it's around just a bit over 35. Next. And in Taiwan, live births with over 4 antenatal visits, it's very high. So it's over 97.6%. So it's a very high usage of prenatal services. Mostly where we miss out is mostly, for example, migrant workers. Sometimes they do not have regular prenatal checkups, and also teen pregnancies. So sometimes they do not have regular prenatal checkups. So that is something that Taiwan has been working on. Next. And in Taiwan, I would say almost all deliveries are attended by OBGYN doctors. So over 99% are delivered by doctors. Less than 1% are delivered by midwives, and unattended deliveries are less than 0.1%. So that kind of gives a general overview of the obstetric care in Taiwan and kind of how the situation is. So just a very, very quick summary. Basically, we have aging population. With aging population, we also have a dropping fertility rate. With dropping fertility rate, our pregnancies, the average age of our pregnancies are increasing, which means that high-risk pregnancies are also increasing. And so the challenge there is to have a proper screening program in order to screen out these high-risk pregnancies, in order to keep our rates relatively low, and also to keep in mind the cesarean section rate, so we do not have any waste in kind of the health system, the medical resources. And in terms of prenatal deliveries attended by physicians and midwives, I think Taiwan is doing pretty good on that end. And so I'm just going to go into the prenatal checkup program in Taiwan. Next slide. Yeah, next. Okay, so the Ministry of Health in Taiwan provides 14 free prenatal care in Taiwan. And so is everything okay? All right, I'll just keep going. The Ministry of Health provides 14 free checkups. And so in the first trimester, it's at 8 weeks and 12 weeks. As we go into the second trimester, it's every month, so every 4 weeks. And then as we go into the second trimester, up to just before term, it is every 2 weeks, and then it's weekly after 37 weeks of gestation. And just a very, very quick overview. The government also provides 3 free ultrasounds. So once between 8 weeks and 16 weeks, once between 20 weeks and 30 weeks, and once between 32 weeks and until delivery. So the range of these weeks for the ultrasound is kept very wide. This is on purpose, just so each doctor can tailor these ultrasounds to just according to their own expertise and their own management. However, in my experience, most obstetricians in Taiwan do provide extra ultrasounds, so at least once every month. So we do order extra ultrasounds apart from these 3, which is free from the government. So there is a little bit of extra cost, included if you do want to do more ultrasounds than these 3. And in terms of other exams, we do have a first trimester blood test, and we have a GDM screening and anemia screening at between 24 weeks to 28 weeks. Syphilis screening at 32 weeks, and GBS after 35 weeks. So these are what the government provides for free to our pregnant women. In terms of other services that we can choose to provide is genetic screening in first trimester, and also high-level, so very targeted anatomy, ultrasound, and fetal echocardiography at around 20 weeks. So this is just a general overview. Next. And so what do we provide during a routine checkup? I'm sure it's pretty similar everywhere. So the same thing, history taking, asking if there are any current symptoms, vital signs, especially blood pressure for to screen for preeclampsia, urine protein, urine glucose, fetal movement, fetal heartbeat, and education and counseling. So depending on which trimester the woman is at. And so this is just to help identify high-risk pregnancies or if there are any complications for further management. So we do this for all of the 14 checkups. Next. Just more detail, first trimester, we look at the blood count, blood type, and then infectious disease screening. For genetic screening, which would be out of pocket, but it is provided, for example, SMA, Fragile X. In terms of down screening, you can do early anatomy scan and look at the nuchal fold, along with some biomarkers, or you can also choose to do non-invasive prenatal screening and IPS for it. So this depends on the pregnant woman and also how the doctor decides. For ultrasound, we can do an early anatomy scan. This usually goes with the down screening, first trimester down screenings. And for others, we also can provide a preeclampsia screening, so where we look at the fetal Doppler along with some biomarkers. So this we can screen for people who are at high risk for preeclampsia. If they are in the high risk group, then we start aspirin. Next. In the second trimester, if they did not do first trimester down screening, we can do a quad test if we want, and like I mentioned before, fetal echocardiography and targeted anatomy scan at around 20 weeks. We also do a GDM screening. So in Taiwan, we do provide free, it's 75 grams OGTT test. However, if the woman opts to or would like to, we can also do a 50 gram screening first and then a 100 gram OGTT. However, this would be out of pocket. So if we want to use what's provided freely by the government, it would be the 75 gram. And we also do anemia screening, so we just look at the hemoglobin. Next. And as we get into the third trimester, we do a syphilis screening again. So for syphilis, we screen for in the first trimester and again in the third trimester. And then, of course, GBS screening and ultrasound as needed by the obstetrician. So that gives a general overview of the kind of the antenatal care program in Taiwan. Next. And in terms of just very quickly intrapartum care. So in Taiwan, like I mentioned before, almost over 99% of the deliveries are overseen by doctors, which means that most deliveries do take place in hospitals or in clinics. And so from my understanding, we usually do have intrapartum monitoring. Most larger hospitals, they have a central monitor system. If not, most people do intermittent Doppler just in between, for example, like the contractions, for just to check the fetal heartbeat. Do active management of third stage of labor, and then there's postpartum monitoring that our nurses do for us. And then if there are any problems, for example, on PPH, we do have established PPH protocols for all of the hospitals and clinics to follow. Yeah, so that just gives a general overview of the care in Taiwan. Are there any questions or? Otherwise, that's the end of my presentation.
Thank you, Dr. Lee Hao. Our question and answer, I guess it will be for the panel discussion in a bit. So our next speaker, I'd like to welcome our Reproductive Health Director, Caroline Johnny Chibas, to present to us on reproductive, maternal, neonatal, child, and adolescent health and policies. Come on.
Kumpul Dr. Jean. Before I proceed, Yagwe Olep. Yagwe. Good morning. Mensang Mao. Lenwo. Pula. Okay, before I proceed with my short presentation, first of all, we want to thank the Lord for this beautiful day. Thank Him for all His blessings. Thank Him for the rain today. And thank you, NCD, for this invitation, for us to share these program activities that we've been implementing. So, my name is Caroline Johnny Chibad. In Pohnpei, they call me Caroline. In Majal, they call me Ligaroline. Okay, so I want to thank our chairperson for the Ramnaka, Dr. Ivy, for giving me this opportunity to present our short update on the Ramnaka policy. So the Ramnaka policy is reproductive, maternal, neonatal, child, and adolescent health. So we have a committee just reestablished in July 2021. We had a committee before, but it was reproductive health only. It didn't include the maternal and neonatal, child, and adolescent. So now we have this committee. It was reestablished in 2021. And the committee provides a forum for regularly discussing strategic directions for improving reproductive health, health of women, newborns, children, and adolescents. The committee's work is driven by the RMI NSP, the 2020 to 2030 health policy objective, specifically for improved maternal, infant, child, and adolescent health, strengthen response and resilience to communicable disease, environmental health, and health emergency preparedness. It also, third one is strengthen neighboring island health services, and the last one is address issues of climate change and human health. So in the squares you see, there are 4 circles. These are the members, include members from the MOHHS, PSS, NGOs like with me, and I'm sorry we haven't really worked with Kidchila, but we can also include them, and MOCIA. And the committee consists of 24 members. We have a lot of members, and one of the challenges when we try to call for a meeting, only few show up. Next slide, please. So this is the Ramnaka policy. The Ramnaka policy strategy and implementation plan has been developed to support the government and all stakeholders within RMI to work towards the full attainment of its citizens' sexual and reproductive health and rights, with particular focus on women, girls, and people with disability. The policy development commenced in July 2022 with the technical assistance from UNFPA. And the progress of this activity was disrupted as RMI responded to COVID-19 outbreaks, which consumed the attention of health system personnel. So currently, there is ongoing feedback on the draft policy, and we're looking forward to the validation and endorsement of this policy. Next slide, please. So this is the vision for the Ramnaka policy. The highest level of health and well-being of all the population of the RMI, especially women, children, young people, people with disability, and other vulnerable groups, through universal access to quality sexual and reproductive health and rights services, and anatomy to make informed decisions about SRH, birth spacing, and protecting behaviors. Next slide, please. So there are 4 goals for this policy. Number 1, equitable access to quality, appropriate public health and clinical services throughout the life cycle without undue financial hardship. Number 2, enabling environment in which individuals, communities, leaders, and service providers work together to promote and facilitate health lifestyles, choices, and health-seeking behaviors. Goal number 3, health sector management and governance, which is informed by and accountable to those who use and need it, and through evidence-based policies and plans. The last goal is mobilizing and working with multiple sectors and organizations to initiate new ways of promoting health and well-being. So in this policy, there are 8 policy areas. Number 1, key policy area number 1, safe motherhood, antenatal, perinatal, postpartum, and newborn care. Number 2, child survival, immunization, nutrition, and prevention and management of childhood illness. Policy area number 3, family planning. Policy area number 4, strengthened health and well-being for young people. Policy area number 5, prevention and management of STIs, including HIV. Policy area number 6, elimination of and response to gender-based violence and sexual assault. Policy area number 7, morbidities of the reproductive system, cancer, infertility, menopause, and abortions. And the last policy area is reproductive health, commodity security. We want to thank the UNFPA for all its support to the program. We have another cervical cancer policy, and they'll be endorsing it today at ICC at 3 p.m. at the With Me conference in collaboration with UNFPA. And we're thankful because we know that RMI has the highest rate of cervical cancer, but we haven't have one policy on that. So just recently, we've been working on the policy through UNFPA, and it's ready for endorsement this afternoon. So if you're free, please stop by and witness this very important occasion. We have other trainings that were also conducted 2023. Sorry, I didn't put it up here. I just came and sat there and I saw my friend's presentation, Dr. Olden. He put up the trainings too. So we had a few trainings we had too with UNFPA. We had the adolescent sexual reproductive health in emergencies where we brought in adolescents from the outer islands so they can learn the commodities, the sexual rights, what to do in emergencies. We also had one training on contraceptive, logistic, and management system on the family planning contraceptives. We also had one training on Tubaya. Tubaya is an assessment tool we use to do assessment in the outer islands on SRH activities. Next slide. Thank you. Come on.
Thank you, Caroline, for the presentation. It is now time for our panel discussion, questioning and answer portion for our presenters this morning. So if you have any questions, we have our mics on our table. You can go ahead. I see two approaching. Who wants to go first? You? Okay, NP Taina, go ahead. Oh, okay. All right. Sure. Go ahead.
Hello, Bola. On maternal, I'm concerned, or I would like to know why the vast difference in the percentage of deliveries that are done for doctors, which is 99%, and the midwives, 1%. Thank you.
Dr. Lee, are you there? Okay, thank you.
Yeah, so sorry, the question was, I didn't quite catch the question.
The vast difference of deliveries done by the doctors, which is 99%. I'm concerned about the midwives, only 1%. Is there a reason? Thank you.
Oh, are you asking, for example, when would someone be delivered by a midwife and when would someone be delivered by a doctor, or?
It's the difference. 99% by doctors and only 1% by midwives.
Okay, I'll try and answer it. I'm not sure I quite get it, but in terms of the difference, I think it really depends on how the health system here is set up. The midwife kind of like program and training, they are starting it. However, it's not really gaining as much traction. And so with the kind of the culture in Taiwan, people are not as used to. So it's not really the norm to be delivered by a midwife. So I think that has kind of a cultural and a kind of historical component to it. However, the government has been trying to increase midwife training and also more usage for with midwives. So I'm not sure if that answers your questions. And in terms of who gets delivered by whom, in general, if it's usually how it works in Taiwan is there would be obstetric clinic. And so there would be a doctor there, and then under the doctor, there would be maybe several midwives. And so during the like the prenatal screening, if for low-risk pregnancies, the midwife would be responsible for that. And if during prenatal screening there are any signs of any high-risk pregnancy, any signs of possible complications, then they would be referred to the doctor. So from my understanding, that's how it works in Taiwan. However, yeah, it's true. The midwife program in Taiwan is not as robust as I think most places in the world.
Thank you. I like the fact that you mentioned there should be any more training on midwives. But I was thinking is there a policy that is in place by the hospital? Maybe, maybe I can give an example for insurances purposes. Because I'm a midwife as well.
Yeah,
I'm
yeah.
really talking about midwives. I challenged the hospital that I went to in Taiwan, and I left that on the table of the nurses. Let's take ownership. We monitored right throughout just for a doctor to deliver. I gave that to them. Keep training midwives. Thank you.
Yeah.
Are there any more questions?
Testy. Manakay?
Okay, go ahead, then we'll.
Okay. I have two questions. O- one for Dr. Olden regarding the mental health. Um, for now, we still don't have children with ADHD. Do we plan to look after any children with ADHD here in Marshall Island? And the other one for the doctor, for the maternal. While looking at your data, I don't see any teen pregnancy. So Taiwan has 0 teen pregnancy, or what's the age group you identify for teen pregnancy? Here in Aramai, we still have a lot of teen pregnancy. And also, can you share some of your PPH protocol so we can also improve our service here? Come on.
So the first question was for Dr. Holden. Go ahead. Then Dr. Lee.
Yes. Thank you for the question. If I heard that correctly, you're asking about ADHD. So currently, we do screening for ADHD when schools or parents bring them over. And after we screen them, when we have a positive screening, we do the full mental health evaluation and make recommendations to the PSS. Once we submit our summaries, PSS provides special teachers for these particular students. So both PSS and private schools get the summaries from us. In terms of medical treatment, we still don't have in our formulary, but we're hoping that the RMI essential truck list add ADHD treatment to our current formulary. We're hoping that next week is Mental Health Day. We're hoping that we have a chance to also get that sometime next week to meet with all nurses, especially wellness clinic and pediatrics, to help us with screening also the public pediatric screening checklist to help increase the referral and identification of children with mental health needs like autism and ADHD. Thank you.
Dr. Lee, the second question is for you. I'm sorry, can you repeat your question again, Chief Nurse Ilya?
regarding the teen pregnancy, how do you define your age group for the teen pregnancy? By looking
Sorry, it's not very clear.
okay. Can you hear me well? How is it?
Yeah.
Okay. My question is by looking at your data, I see that 20 years old is the least of pregnancy. Do you have any other age group under age 20 years old, like 18, 17? Because here in Aramaya, we do have a lot of teen pregnancy. Maybe Nikki can translate to Taiwan, Chinese.
No. Language isn't the problem. I think I got your. So you're asking, do I have any data on the prevalence of pregnancies in the age group 20 and under? Oh, okay. I have not found any, but I think I can probably dig a bit more and get back to you on that. But I do not have it on hand. I would guess it is very, very low. However, just in clinical practice, I have had teen pregnancies in my practice. So I know there are. I don't have the national number for it, but I would guess it would be on the very low side. And I think the second part of the question was PPH protocol. I can definitely get that to you. And then tailor it to how the healthcare system is in the Marshall Islands. Maybe I'll get perhaps your contact information through Nikki or Dr. Ivy, or I can send the flow chart that our hospital uses, or the Taiwanese OB/GYN Association also has their own for each hospital to kind of to tweak.
Thank you, Dr. Lee. Any other questions?
Okay. Good morning. My name is Tavaita. Just a question to mental health. I would like to speak on behalf of our zone nurses in Charles. Is there any plan for training our zone nurses in Charles on mental health, like refresher courses, in terms of our theme, bridging the healthcare gap? For those of our patients who cannot reach out to mental health, when we go out house to house, some of them, all of them are living with NCD, and we need to know the techniques of how to counsel, or how to counsel a person living with stress in terms of NCD. Is there any plan that our zone nurses and Charles will be trained?
We do not have plans now, but this is a potential partnership, because for nearly 3 years we have not carried out any preventive awareness because of lack of funds. I mean, I don't even have fuel fund, but if that partnership will help both sides. We have a team that can give you the screening tests for all the different child and adult mental health conditions, and you have the funds for the community, so we can work together. For the past 2 years, that's how we handled our work in the outer islands. We joined the NCT teams to go out, and we do depression screening on the same ride without paying for our ride. But please, feel free, if you think there's a way we can have a one-day sit-down, just a chow and basic screening and approach that we can work with for the communities, then we're happy to do that.
Thank you. The last question to reproductive health, sorry. I'm thankful that we have a policy in place, but is there any plan, Sorry. Is there any plan for us, for our CHOWs and zone nurses, especially zone nurses that will be leading the CHOWs in the community, in terms of family planning commodities? Is there any, will be there any training for our zone nurses? Any plan to train our zone nurses on family planning or anything about reproductive health? Because when we went out to the community, we've seen a lot of young mothers who are wanting to go back to school, but they are scared to come to the hospital in terms of stigmatization or discrimination, maybe. But I believe the zone nurses will be the one to help our reproductive department preaching the commodities that we have. But we need to be very well knowledgeable first before we market the commodities that we have in our department. Can we be trained or have a refresher training on family planning or reproductive health services? Thank you.
Mankomol Tavaida. Yeah, we have a training next year with family planning New South Wales, and we can invite the zone nurses to be part of this training. It will be provided by UNFPA. But if you need help, you can just stop by at the office.
Thank you very much. Question answered.
Dr. Zach and Dr. Adri then can have. Go ahead.
Yeah, my question is to Director Caroline. You mentioned in your presentation that cervical cancer is high in RMI, and it has been high for a couple of years now, and you don't have a policy on that. And I think that's one of your priority and goal is to put in place a policy. Can you enlighten us with probably some policy in your capacity at the moment? Share it with us, please. Thank you.
Karta kachita ka chaloban.
I parbidi.
Yes, Joyum, repeat the question, please.
Okay. Chaloban we can maigi jar. Kachito kan cancer, cervical cancer. Kunyaba, it is high, low RMI. Okay, you don't have a policy on that at the moment. You maybe?
In Mankomol, Juane policy, cervical cancer policy. And then we validate last week, and they're endorsing it today at ICC.
Oh, okay. Plenty ba nagkakaroon niya? Okay, Mankomol.
Kumol.
Good morning, all. Tavaida raised a very important question about NCD and mental health and training the CHOWs. This shows how important mental health is in NCD care. I just want to share my experience in working with NCD patients that we tend to treat them with their uncontrolled diabetes and hypertension, but we forget their social issues and the issues they're dealing with. Reminding me of Dr. Holden's presentation this morning, are they sleeping well? Are they eating well? If we forget to ask these questions and we keep treating them with these medications, we will increase their doses, add another medications. But just to ask how they are doing, how's life, those things, just mention, because we're not treating the disorders, we're treating the person. So if we just spend another 2 or 3 minutes just to ask them how they are feeling, we might end up finding out that they're dealing with depressions, because it's overwhelming, the thoughts of having diabetes and hypertension and how they will deal with this. And it's just stressful. So if the stress and the anxiety are not dealt with, the blood pressures, the diabetes cannot be controlled. So NCD and mental health are very, very, very related and intertwined all the time. So please do not neglect mental health problems in these patients. Thank you.
Come on. Next question.
It's not a question, Yakweolop.
Yeah,
It's just reiterating what Tavaita mentioned, and I want to thank her for actually bringing it up, as Doctor mentioned. So one of Ministry of Health's priority is decentralizing of services. And we had a program, the Data for Decision Making program, that had trained some of the administrative staff on utilizing their data. And so, long story short, the idea is putting out our services to the communities, utilizing the zone nurses and the CHOWs. And with that, as Tavaita mentioned, each program to conduct refresher trainings for their nurses. So that is all part of ministry's plan, the way moving forward. Instead of waiting for patients coming to the institution or the hospital, we are going to empower our zoning outreach units with the help of the registry data unit. So just wanted to put more information into that. Komol Tata to the zone teams and the CHOWs as well. Komol.
Any other questions or additions, recommendations?
Good morning and Bula again. This is to our pediatrician. Thank you for your informative presentation. I just want to thank you for showing us the picture of how you set up your clinic, the pediatric clinic and the other wellness. And you mentioned something that captured my 2 doors. The plan for your MCH clinic, the one you have in your presentation. And I like it because you have a pediatric clinic and maybe your wellness, and you mentioned something that captured me, 2 doors. Those who are sick go in this door, and those who come in for the clinic go in this door. I just want to thank you for that. And I think so that's probably a recommendation for us on our end, RMI. Thank you.
Thank you. Any more? Okay, Dr. Zach, go ahead.
Right. Very well recommendation. You know, on Takda Adriba, Magdalene and NCD, very important. Ngan Kakubaba, Magdalene and TB also important. Right, Dr. Walden?
Thank you for that. Okay, we have one question here on this other table. Go ahead.
Okay. Yagwe, this one is for Dr. Olden. Hi, Mida John from the In-City Clinic. I've been curious about our clients that are living with NCD, mostly diabetes and hypertension. What are your management? We can see some of them. We are providing services for eye, Tendo, and do they get these services?
Thank you for the question. You're asking about patients that are within our program.
Within your program that are living with the NCD and they have complications, some of them, they're walking around and we can see that they're having their, visions, they're walking with wounds. What are their management for these clients?
Thank you very much. That's the essential aspect of mental health, where mental health, you don't really talk about what they have. But we try in the program, all cases that we have, for females, for example, the female staff try to make sure they have their annual women's screenings. Those with blood sugar elevations, we send them to the diabetic and NCD clinics. To go for dental, there's a referral. So we do referral to all programs. We try not to micromanage the cases. Just like every other patient in the hospital, we refer to the right departments for each symptom that they have.
One more. As I mentioned, I'm working at the NCD clinic, and maybe we could, collaborate, work together, and try to bring them in, set up plan for them, for management, and for the services. Maybe we can start to work together again. Just a recommendation for.
Thank you very much. That's very important to us. I'll take it back to our team, but please also feel free to walk in anytime. That kind of observation to help improve the service we provide for patients is highly appreciated. Thank you.
Any more questions, additions, recommendations? Oh, one more. I see one more hand at the back. Okay, go ahead.
Thank you. Hello, everyone. It's just a recommendation that we need to have our CPR card up to date so that, especially for the show nurses, when they're out in the community and then they encounter emergencies, they can be able to help. Card. Okay, thank you.
Thank you, Nurse Ann. Okay, I'd like to thank everyone for your questions, comments, recommendations, and interaction during the panel discussion. It is now time for our lunch. So I'd like to, may I ask Pastor to please come forward and bless our food before we go to get our lunch.
Malkumul future. Jadi na baru kan jim kau di sini kulo. Elegan ralevan rajin perjuangan. Kajar kaman ralevan mengagin kempojan pugi ngan kakajur. Aji waj cabar tuwa wanu cabar ngan input. Ngai caram koli. Rata ngai car kacite mengagin. Rene rempai demi nak pugi ngan murkenan. Kumolo. Amen.
Amen. Thank you, presenters. Thank you, speakers. Please be back at 1 o'clock to begin our afternoon All right, congratulations, winners. At this time, I'd like to welcome from Taiwan Technical Mission Nutrition Specialist, Cynthia Lee, to talk about agriculture, nutrition. Come on.
Yagwe Aolip. My name is Cynthia Lee, and we have the partner. Let me introduce my partner is our horticulture specialist, Alex, and also nutrition assistant, Berlin. So today we are talking about another part is about the horticulture and nutrition. So actually through this okay, so actually for these pictures, that is a very common situation in Marshall Island. Like an unbalanced meal and less vegetables, this situation is very common in street food and also for the school meals. So actually, you can think about, okay, this is our school meals, and also this is very common to in our street food. So you might start to think about, okay, how can we do for that? So we're starting to put some vegetables into their lunch boxes. But what we found out even we put the vegetables in their plates, but the students still don't eat it, and even take it out, spit it out away. So it might be very interesting. Why? Because vegetable is so important for prevent the NCD, diabetes, so many parts. But why even we provide the free veg for them, even that they didn't take it, eat it. So for the left hand is the radish, and on the right side is the the eggplants. So you can see this situation is very common in our campus. So you might need to think about, okay, probably it's the problem from the vendor. Probably they cook too not very well or something, or probably you will think about, okay, students might not know that vegetables, or probably is another situation is because nobody eat that, so I don't want to eat it. Probably it's just the eating atmosphere. All of this situation, you are thinking about, okay, why? All of the why, actually, I'm agree of your idea. Because I have to say, nutrition education is very complicated. Especially, we want to change their behavior. It's too complicated. So how complicated? Through this a model. This is model from the Dr. Isabel Contento. For the nutrition education, we can know if we want to become a very positive attitude or behavior, actually very complicated. It will relate to the personal. For example, probably he don't like it because before the eating experience is not very well. And another thing is probably he doesn't know that. And even he doesn't know, okay, how to cook the radish or eggplant like that. Another things also relate to the family and home. Probably these things is never show up on their table. And of course, about the vegetable, is it affordable for us? Or where can I buy it? Especially for outer island. And also for the supermarket, probably sometimes we buy it in a fresh status. But after 1 week, it's getting bad. So how? And another part also relate to the social and environment. So all of the things actually will relate to nutrition behavior. So here we want to share some survey from our students. There is some interesting things. So through this table, on the left side, you can see most of the students they know lettuce, green bell pepper, chili, long bean, cucumber, eggplants, cherry, tomato, and lots of the local food. But on the right side, with the red part, you can see more than half students, actually they don't know bitter melon, lupus, asparagus. And more than 1/4, under than 50, half students, actually most of the green leafy one, they don't know. So that is an interesting thing because compared to the plant, okay, compared to a local farmer, we can find out, okay, what's going on to these students? Most of their knowledge, they learn about this vegetable. Actually, they know more about the imported food and also with the canned food. But for the local, really from the farm, from the local farmer, the green leafy one, actually they really seldom to touch, approach about it. So it's a very interesting survey for us. And another thing is we also do the survey for the students to see what kind of the vegetables is the students like. So you can see more than half students they like cucumber, banana, pineapple, papaya, kind of these vegetables. But you can see only one cucumber is really belong to vegetables. Is it interesting? And for the left side, we can see lettuce, green onion, and green bell pepper is their most vegetables. So what it means, it can connect with our local farmer. Okay, so today, actually, we have 2 parts. Some small experience would like to share with you. The first part, I want to introduce about the Agriculture Nutrition Club in MIHS. And another part will be the Unale Baim Veggie Day. It's for our school lunch program. So what is about the horticulture nutrition education? The very important things is hands-on. All of things needs to be hands-on. So we let the students start from the seed to the vegetables. And I have to say, horticulture is not a very popular or very interesting things because our students, they don't, they are really cute girl, pretty girl, and actually under the sun, it's a very hard work. They don't like to go to the garden. I have to say, it's a very challenge for us. So we start to let the students try from seed and through the nursery, transplant, even let them try to do some home garden, and in the end, we harvest all of the vegetables. What we're gonna do, because we want to let the students know about various vegetables and that it is possible from your garden, and to learn how to use these vegetables. For example, not only sell, because most of our marshallers, when we harvest it, we want to sell it to earn money. But who's gonna buy the vegetables? Foreigner? It's not make sense, right? So we start to let students know, okay, after harvest, not only sell this option, we can also do some plates and to sell. Another thing is we can keep it like a food resource in our house. So for the nutrition, horticulture nutrition, for the nutrition part, we start to let the students also hands-on all of the vegetables from the school garden, okay? So the main purpose is we want to let them know how to make a balanced meal and how to use all of the vegetables. Even these vegetables is really new for us. It's really new for everyone. So how to do that? We start to give them some nutrition and cooking idea and leading them, start from design the plate, make the plate, even sell it, try to sell it. Okay, so for the balanced meal, not only just rely on imported food, we have to teach them how to mix with the local food, with the imported food will be their main topic. Not only that, every time, actually, we have 10 classes with them for each semester and with 2 activities. Because for the nutrition education, not only cooking, not only knowledge, but also we have to leading them to go to supermarket and to learn. Why? Because I have to say, imported food is one of the main food resource for martialists. But how to do the select? We teach students, you always have the best choice. But before that, you have to know about the nutrition label. It's the truth. For example, once a time when I go to the outer island, I have to say, on my trip, I can't bring a lot of the fresh vegetables. So replace that, I bring some like frozen vegetables or canned one to become one of the resource of my vegetables eating. Okay, so we teach students always have the better choice. And another things, we know to make a positive behavior is really hard. So actually our goal is put down the attitude, the positive attitude. What it means? It means when we provide a free vegetable in front or even on our place, they will have the willing, would like to eat it and choose it. That is what we want, because we know, because they don't have the money, probably. They don't have the food. They don't have so many reasons that will relate to the behavior. So another part, we also will visit Laura Farm and local farmer. Okay, and this is all of the place from our students' design. We try to let them to think about how to mix with the imported food with the local food, and how to put the vegetables in their local foods. For example, the pumpkin veggie rice bobo, in martialists, they usually will eat the sweet one. But we try to let them learn how to put the vegetables inside. And in the end, actually, it's like a kind of a salty one, because we put some ground pork inside, fried with veg inside. But for the pumpkin sushi roll, as we know, it's usually tasted like a salty one, right? We usually put tuna, we usually put something inside. But in this time, we put the cucumber, apple, pumpkin. We try to make it balanced and interesting. So after that, we also let the students go to sell, try to sell to somebody, and they need to learn how to do the presentation. That is what from they. So what's our find out? There is interesting things. These students, they can become our assistant and also help us to teach other students, teach the elementary students. And there is another story I would like to share to you, is about the second picture, the tuna with kangkong. That is the dish from our students. They just use the leftover, something, we put some onion, kangkong, egg, just to put in the fridge. And the student asked me, teacher, we don't have the lunch. Can I use your ingredient to make some plates? And I said, sure, go and get. But we need to have 6 people. We need to eat it. Can you do that? And he said, why not? Just to go and starting to do the working. And that is the play from him. Is it look better? I think it's better, less street food, right? Compared to $4. And he told me, oh, $4 is too expensive. I did that. So cheap. Okay? So, and the third picture is from one day I made a nutrition training to these students. And I just left because I said, okay, afternoon I'm gonna come back because I'm gonna check your presentation. So the student is really hard in prepare the presentation for me, but they just have 30 minutes for eating the lunch. So when I come and see, what's going on? Why are you eating ramen? And say, check. So he's starting to, take out all of the ramen and say, no, miss, we fry the beano with the egg, and we put into the ramen, mix with it, and we eat it. So what you find out, actually they will know how to prepare balanced meal and how to do it quickly and using all of the ingredients from what they could. And the final picture is from their home garden. Some of the students, they learn some skill from our school garden and bring it back and starting to do their home garden. So actually we have to say, vegetable, they use it any way, any cooking, whatever, just eat it. So this is their homework. They start to try to put the kangkong, beano, and ali, and also cucumber. Try to let their food, dinner, colorful. And on the right side, the upper pictures, you can also see the students starting to make the plates. This concept is very interesting. And some of the students starting, become the main cooker in their home. Another program I would like to share is Unale BAM Veggie Day. That is another part from TTM, collaborate with the MIHS. So actually, for this program, we'd like to put some vegetables in their lunch boxes. So since from this year, we're starting to try twice a month to once a week to provide vegetables to their lunch boxes. So you can see actually before this is the lunch boxes from them. After we put some veggie, it's starting to get in some interesting, some more balance for that. So this is the end. Taiwan Economic Commission, we have two programs in the RMI. Two of the programs, one of it is enhancing nutrition balance through agricultural production. So we have 3 specialists here. And another project is livestock expansion project. Okay, so finally, this is the end. We want to thank you all of our partners. Collaborate with the PSS, MIHS, and also NRC. And thank you for your be here and to listen to our presentation. Thank you so much. Thank you.
Thank you, Cynthia Lee, for the presentation. I'd now like to welcome our Wellness Director, Tanner Smith, to present to us on Wellness Center programs.
All right, Kakuya Hey, just going to showcase some of the things we've been doing at the Wellness Center and how they kind of interact with everything else. So yeah, we had the Heart Healthy campaign and the Prediabetes campaign are the 2 kind of main ones we have going now. The Prediabetes one is pretty interesting because it actually works to kind of reverse the diabetes epidemic out here before it gets to that diabetes state. So, if you want to really, statistically speaking anyway, turn things around out here, you're gonna have to stop the people that are on their way to becoming diabetic from reaching that level. And this program uses lifestyle coaches. It's a year long and we see anywhere from 100 to 200 people. We were able to put this into the outer islands with Zoom equipment and partnerships with CMI. So it's on Ebon, Wutje, and Jalowit right now. And eBay also has another part of this program. And then the Heart Healthy campaign, we have 2 blood pressure kiosk stations. I don't know if you've seen the one at the Wellness Center right now, but there's another one on its way, and we hope to just kind of build on that and raise awareness of hypertension by people coming in, getting screened. Okay. Go. So, I've used the abbreviations, but CDSMP is the chronic disease self-care, self-management, and DSME is diabetes self-management. So these are 2 courses. They're about 6 weeks long on each course, and they teach people how to do the self-care for themselves, basically. And then the school health program, that one's really good, working with MOH, health promotion team, PSS, to encourage physical activity in the schools. We did a study, what was it 2020, 21, that showed that the linkage between obesity in the schools was with whether people met the WHO requirements for physical activity. So, all right. And then the home garden program, linking in with Taiwan Technical Mission and NRC, we put in about 100 home gardens on Madro and a few in Jalowit and Wuche, and we want to keep that going. We want to keep those maintained. And then physical activity for the youth, of course, coordinating with MOH, MOE to do physical activity, PE programs coming out soon. So those are some of the things that we have going on right now, reaching out to eBay, Jalowit, Wuche, and the schools and the communities to do those. So we're hoping to be able to really launch the PE program hopefully end of this year. We'll see where it goes. All right, I think that's okay. Thank you.
Thank you, Tanner. At this time, I'd like to welcome from Taipei Medical University, Shuanghu Hospital, Dr. Sheng Chen Chang via Zoom. He'll be presenting to us on diabetic wound care and prevention RMI conference. Hi, Dr. Chang. Okay, hold on.
So, colleagues, can you hear me?
Yes, we can. Yes, we can hear you.
Excuse me, can you hear me?
Yeah.
Yes. Okay. Okay, sorry. Good afternoon, everyone. My dear friends and colleagues. And this afternoon, I will share my experience about diabetic wound care and the prevention. I'm from Taiwan, Taipei Medical University, Shuanghe Hospital. I'm Stephen. Next slide. Next slide, please. Next slide, please. Okay, this is okay. I can. Previous slide. Previous slide. Yes. Okay. This is my memory from Marshall Island from this July to August. Okay, next. Okay, next. Okay, next. The diabetic crisis make every nation to use more and more budget to treatment the diabetic complications. The budget is increased year by year. Next slide. Next.
Financial burden 的这一张 slide， 你那边看到的是哪一个？
是 financial 的。
OK， 所以 下一张哈。
Okay, okay, excuse me, may I share my slide from my computer?
Okay, sure.
Okay. Okay.
主任，你可以 share 了。
哦。嗯。按哪一个啊？中间的通话应该是。我知道。点那中间。啊？点那个中间。这里看。哦，有，好，分享方面。绿色。绿色。我还是被禁止分享画面。
再一次，不好意思。
哎，好的，可以了哈。
有看到了。
看到了哈，谢谢。可以看到吗？
有。
Hello。
有看到。但主任，你可以改成全荧幕
我看到
的，全荧幕的吗？因为这样子好像会看到旁边的那个备忘录。
好，我了解，可是我有，我看一下。我把这个划掉。OK， 这样可以吗？
这样可以。可以。
OK。因为我这里开始的这个状况跟那边的时代会有 delay 的现象，还蛮明显的。
现在是 DFU vs cancer。
Yes. Okay, I try to start again. Now we use more and more budget to treatment diabetic foot ulcer, but you can see the outcome was very poor, and the survival possibility is only superior than lung cancer after major amputation of diabetic foot ulcer. You can see the 5-year survival rate is almost 50% after major amputation. The survival rate is superior only than lung cancer because we know lung cancer is very, very poor survival. Okay, we need to know, we don't need to see only this wound. We need to see the whole body during the treatment of diabetic foot ulcer. Because diabetes is a systemic syndrome to involve whole body, nerve, artery, heart, kidney, and the other organs. Diabetic foot ulcer is a very complicated pathogenesis combined with arteriopathy, neuropathy, and infection, with some predisposing factors to trigger the ulcer occurrence and the ulcer progressive to the deep infection and finally receive amputation. Diabetic ulcer is a multi-disorder of our organs. And finally, progression to superficial and to deep ulcers. And finally, foot become necrosis and receive amputation. The major issue of diabetic foot ulcer is neuropathy. This is sensory neuropathy, means no sensation, no protective ability to our foot. When we are suffering with burn injury or stabbing injury or other trauma. The motor neuropathy make our foot become deformity and our weight-bearing point become changed. And the autonomic neuropathy will change our support of our bone, become the shackle foot deformity and anhydrosis of our skin on the foot. Commonly, the diabetic foot ulcer was classified by Wegener classification. The Wegener classification was the most important stage is stage 3, because the ulcer involved to bone and the osteomyelitis occurrence on grade 3. And the grade 4 is partial toe gangrene, partial foot gangrene. And the Wegener 5 is total foot gangrene and need to receive major limb amputation. So we need to protect our patient far from grade 5. And before the grading of grade 4, we can try to preserve our foot, our ankle, and can make patient stand up by himself. The other common used classification is Texas classification. The one issue is ulcer involvement depth, from superficial to tendon to bone. And the other issue was infection and ischemia, and combined. So this classification can help us to know the other concepts about the foot, just like infection, the severity of infection, severity of ischemia, or combined ischemia and infection. We need to use the TIME concepts to perform our wound evaluation every day. Include the T means tissue, the color, the gangrene, infection or granulation state, infection or inflammation. If the infection is severity, to strengthen the limb, we need to use antibiotics and the debridement. M is moisture. We need to keep our wound in moisture environment. And the underlying and the rolling edge need to be refreshed to the fresh edge and facilitate epicellization. So the TIME concept is important to evaluate our diabetic foot ulcer. In 2023, the new IWGDF guideline was presented on a paper. It's a very multidisciplinary concepts about practical prevention, classification, and the methodology. And the other offloading and the PAD survey, charcoal treatment, and the wound healing, and the definition and the criteria. The most important concept is if we try to perform the good quality of diabetic foot ulcer care, we need to organize the multidisciplinary team and to set up the comprehensive care plan. Just like the suggestion from the Washington, D.C. University of Georgetown Medical Center, the example of how to survey and how to build up the multidisciplinary clinical team. In our Shuanghe Hospital, our diabetic foot care team include the doctor, nursing, head nurse, and NP, and wound care nurse, and our occupational therapeutist. And the other multidisciplinary team of wound care, we divided to 5 stages, and in each stage we have different section and different division specialists to take care of the diabetic foot ulcer. Just like in critical and ischemic status, we have the nephrologist, medical doctor, cardiovascular, medical doctor or surgeon, and our nutritionist, and the infection control specialist, and even psychiatrist to help patients and their family to obtain the holistic care of diabetic foot ulcer. And the VIPDF plan is very important. Just the plan can help us to know that when we treatment of diabetic foot ulcer, we need to survey and reconstructive the vessel obstruction, the infection and the necrosis, the pressure relief, offloading, and the debridement of wound. After we complete the VIPD, we can use some new strategy to cure the wound, just like a new drug, hyperbaric oxygen, negative pressure wound therapy, flap and skin graft surgery, and a cellular thermometry, and maybe cell therapy. This is V. We need to survey vascular condition and use the percutaneous angioplasty to restore the foot circulation. You can see the temperature can improve after percutaneous angioplasty. And the transcutaneous oxygenation also improved after revascularization. Infection control is important, so I show the biofilm treatment during every visit of diabetic foot ulcer. You can use a very simple method to remove the biofilm on the wound surface. We remove the very thin film, biofilm on the wound surface and refresh the wound far from the wound infection. This is a concept of biofilm control on wound surface. I also use the spatial tool to examination of biofilm. Before debridement, you can see the green light reflects on the wound surface, and after debridement, the wound becomes red and fresh, and all green line was gone. You can see a very clean wound when we treatment of wound infection. The charcoal foot and the foot deformity need to control and protect by the appropriate insole of diabetic foot ulcer. This is the insole, different kind of insole to support the plantar foot, especially during patient receive amputation. The footprint may be changed, and we need to support more when the patient walking and standing. This figure compare the different recurrent rate if we wear the insole or not. If we can wear the appropriate insole, you can see the significant lower recurrent rate of diabetic foot ulcer. We need to very aggressive debridement to remove the necrotic slough and the debris on wound surface. This is debridement surgery. Debridement is very important, and the wound culture is also necessary when we treatment of wound. And we can use the disinfect machine, UVC 222 sterilizer, and use the molecular check our debridement is adequate or not. A negative pressure therapy is also effective to treatment wound and perform the good wound preparation before definite reconstruction, just like skin graft or flap surgery. And finally, we can get a very good outcome. The artificial dermis is also can use to cover the chronic ulcer and finally facilitate wound healing. You can see the toe joint exposure, and after we use the artificial dermis to cover, and finally the wound heal completely. This is hyperbaric oxygen adjunctive therapy before treatment, and finally the foot was all preserved. And I also can use some fat stem cell to installation surrounding the wound surface and the wound area and the wound edge. And finally, the wound also heal. The new drug, Bespisone, is also effective to treatment of diabetic foot ulcer. The clinical trial revealed the significant improvement when we use Bespisone to cover the wound surface compared to Aquacel. It's a very effective, promising results of the new drugs, especially in deeper grade 2 wound, plantar wound, poor DM control wound, and the smoking wound, and also prolonged than 6 months. The Bespisone can also be used before grade 3. If grade 3 with osteomyelitis, grade 4, or even grade 5 is not indicated to use this kind of drugs. you need to do VIPD first to control the wound condition and downgrade the diabetic foot ulcer grading. And then you can use the new drugs. And we are very happy to have the new drugs in Marshall Island. Now you can ask our wound care team in Marshall Island. You can get the new drugs to treatment your patients. The suggestion of apply Fixon cream is illustrated on this slide. You can see the very good outcome after you use the new drugs. This is the other case with capsule exposure and the infection. You can see after 10 weeks, the wound healed completely. This is the other case from first week. After 7 weeks, the wound healed. After use this kind of new drugs. We also need to educate our patients during every visit of diabetic foot ulcer. You need to teach them how to remove the dressing, how to clean the dressing, how to use the dressing material correctly. And you need to arrange them visit to your clinic. And to need to take care of not only wound, but also blood sugar, vascular condition, and the other medical need. And we also need to teach them how to prevention the ulcer recurrence. Just like daily wash and dry well, especially between toes, and the feel for bumps or temperature change. And look between toes, check each toenail, and file toenails straight across, check for dry, critical skin and the facial skin, and the examination button of the feet, and check what you find, and record it, and to take the record to your doctor. So you can see the 4 words. The important one is clean, lubricate, offloading, and revisit every day. And this is the suggestion from the cardiothoracic and the vascular surgeon. They have some diabetes amputation warning signs. It's for you to teach your patient for correct education of diabetic foot ulcer prevention. Finally, we need to identify the correct grading of diabetic foot ulcer first, and the treatment as reconstruction of the vessel occlusion, and the infection control with culture and the antibiotics, adequate offloading to wear the offloading insoles to debrid with a high quality infection control. And finally, you can use the new drug, new strategy to facilitate the final wound healing, just like the new drugs. And this is a great memory to me. This is my day in Marshall Island, and I'm very happy to join the jury when I was very smooth period when I in Marshall Island. And I hope the diabetes food can be improved the control quality or treatment quality in your nations. And we can try to do together to each other to help the patients in Marshall Island, even in Taiwan. This is my talk today. Thank you very much.
Thank you, Dr. Chang. At this time, I'd like to welcome up front Dr. Zacharias to give us topics on TB and DM collaboration.
Yakin relip. Itu jiri ni kenal siapa yang meninggal wajah. Sorry, that's not the topic. My topic is TM and TB collaboration. And the reason I put this one is because myself and Dr. Kyle are going to Geneva next week, if God plan. And that's our presentation with the WHO is TM, diabetes, or NCD, and TB collaboration. And before I actually touch base on the collaboration for both our program, I'd like to give you some input or insight of what we've been doing on the TB, tuberculosis in major Marshall Island. So that's my outline, even though it's a very long outline, but it will come to a 10-minute presentation, I hope. So, next slide. Can you read this one clear? I hope so. Anyway, we know that RMI composed of 24 adult group, and they are this pair over 181.43 kilometer. This is a geographic challenge that limit healthcare force and also centralized healthcare program limit service delivery to the other island. We know that the focus now is more on the outer island, not only for TB, but the NCD as well. We hear from some presentation from wellness. They also go to the other island, NRC, and the rest. Anyway, this is one of our disease burden. Not only NCD, but TB is also a well-known burden for worldwide. I put this picture because I like to show where the Marshall Island is, and you probably know about this picture. There are some drivers for TB disease and TB infection. TB infection is actually, that's the latent TB. So I'm not going to go list by one, but one of the drivers for the TB disease is diabetes. And of course, poor nutrition, smoking, stress, cancer, and many more. But diabetes is one of them. That's why we need to collaborate together with that. The other slide, the biologist highlight where the incidence of the RMI is. It's more than 300 cases per 100,000. Okay. As compared to the other region, we are on the top list for the incidence of TB. Next. This is a one slide show for the mass peak screening in Majuro. That was in 2018. And as you can see, 22,000 plus were registered. But actually, it was 19,000, or almost 200, almost 20,000 were actually completed screening. That account for, no, it doesn't say the percent, but it's more than 80%. Anyway, with that, the other red line at the bottom is, that was the number of people who were screened and found we have diabetes. That was 900 some. That's account for 24%. And among these people who were having screened for diabetes, there were like 400. That's account for 11%. So that's a quite big number. More than 10% is, those were the ones that have elevated diabetes among the people who were screened. But from that screening, there were like 307 were having active TB. Next. This is the map for neighboring island who are having they have a data. Those are the yellow one are the medium range, and the green one are the one with the low incident. But those two top one are Majuro and Evi. They were having a very high incident rate of more than 300 and 400 cases per 100,000. And you see the star, those are the islands that were done for TB mass screening in the outer island, including the two urban area. I don't have a data for Ibai, but it was also done for their mass screening area. The blue star is Island Lablab and Jabat. And that was the one that we did the mass screening this year in June. And just 2 weeks ago, I went there for follow-up on the 103 case of TB to put them back on the, they were taking 4-truck TB. Now they are on the 2-truck or continuous-based treatment. The last trip is going to be in December or early January. That's the summary of the whole outer island or neighboring island mass screening. We started in Arno. After Majuro, we went to Arno in 2019 and 2020. We did 2 groups because the first group was 324. That's about 34%. We brought them from Arno, the close by island, to Majuro. And we bring them group by group, 15, 20, group. And we did it for 3-4 months. And then we decided to go actually over there to Arno to do the mass screening. And there, when we brought these 300 people, there were like 34 cases of active TB. And they were put on treatment and sent back to Arno. The second group was actually the TB mass screening was 600 some. That accounts for 63%. And there were only 4 cases. But even though there were only 4 cases, but the whole island was screened. Okay? Out of that, there was only 1 diabetes among the 4 cases. Then followed by Challis in 2021. Okay? Out of that 1,000 something, there were like only 6 cases of TB. And those 6 cases, only 2 of them were having diabetes and TB. Then Wache, we did it in 2022, that was last year. Another 1,000 some people were screened for diabetes, and there were like 338 were screened for diabetes and having diabetes. That number also come up with, 85 of them were having glucose of more than 200. And there were 24 cases of that diabetes and TB. Okay? And then followed by island level up. I just mentioned the number for island level up. Okay. 24 cases out of that. Next. I'm not going to go over the setup for all these at all, but these are the setup for Arno, followed by Challis. And if you can read it from your end, I also mentioned the one that I put in the box, the black box. That's the account for the diabetes. 79 or diabetes case. That's account for 7%. And then LDBI case, so and so on. So this one is for the island level. That's the latest TB mass screening. Some TB trend for the last 3-4 years in our TB registry. 2020, well, like 28%. 28 TB TM case. In 2021, they were like 47%. In 2022, they were like 36. That's account for 39 or almost 40%. Then this year, combination of island level up and Majuro, they were like 160, 166, but they were like 103 from island level up alone. That's for 25 case of diabetes who were having TB. Next. So this is actually the part that myself and Dr. Kyle are going to present to the Geneva WHO meeting for our TB, diabetes integration and collaboration. And that's the topic they want us to do. Experience of introduction and implementation of collaboration, TB and diabetes activity. So we all know that diabetes is a burden to our country. And we also know that there are risk factors for having a TB. And there are 3 groups I want to mention about, but there are more, but the 3 of them are like untreated HIV case is having a very high risk for developing TB. We know that we have some HIV case on the island. There's about 7 of them, but none of them are having TB. They are regularly, annually screened for TB. Children under 5 years of age also have a risk factor. And diabetes, of course, have 3 times risk for developing TB. And this is why we want to marry both TB and diabetes so we can manage them in a good collaborative approach. one slide from the hybrid survey that was done in 2018. I know Dr. Frank mentioned some of the hybrid table, but just for the chronic disease, diabetes is one of them. And in 2020, that was like 20%. Moving forward to 2018, come up with 26. I think right now he's approaching 30 or probably more than 30. I don't have that data, but I saw it somewhere. Okay? So our collaboration action on TB and NCD or diabetes mainly, in the contest, we also know that, sorry, next slide. Okay? We also know that diabetes is high prevalent and it's continued to rise nowadays. Even young adult, 30 plus year, they are also having diabetes. And with that, they have a high risk for developing TB, especially if somebody is having active TB in the household. Who are the key factor? Ourselves, MOH, our government, NGO, wellness, NRC, you name it, primary health care, Outer Island, and TB and NCD program, and many more. All of us, we are the key factor to tackle or fight for NCD, okay, and TB. What is our intervention? We want to merge and strengthen our work with NCD, especially diabetes clinic. And both of these are under primary health care division, and we want to work alongside with our NGO, wellness, and this is our responsibility as a healthcare worker, both on TB and diabetes clinic. And we want to scale it up in our approach. That's our approach. Okay? RMI will require a scale up and to sustain a responsive over successive year to ensure a meaningful decline in incidence of both TB and diabetes. We want to reach out hard to the population out in the neighboring island and also promote universal health coverage. And that's the key to leaving no one behind. What is our approach? We want to use the health boat, Lued on the Moor, okay, to reach them, to reach the neighboring island, to do a TB mass screening, and also test and treat on the spot. Some of our activity in the clinic right now is both of us are integrated, and for our active case, all active cases of TB are screened for diabetes. We use A1C as well as the random and fasting blood sugar. When somebody is put on a treatment, they are screened for diabetes. If someone is having RPS of 2,200, then they are automatically getting A1C test. Even in OBD, emergency ward, inpatient ward, if somebody is having symptom of diabetes, TB, then they are also referred for us to do a workup. TB and diabetes case who are uncontrolled, they are treated for TB for 9 months. While the regular patient who are non-diabetes, they are treated for 6 months course. Okay. And in all our TB mass screening in the outer island, we always do diabetes screening. And if somebody is having diabetes, we treat them on the spot. I took this slide from one of the sources that Dr. Frank gave it to me and Dr. Kyle, which this is the Pacific standard for management of tuberculosis and diabetes. And almost all of these, I'm not going to read everything, we are doing it. For example, standard 1, we are screening for diabetes in person with TB. Standard 2, every person with diabetes should be screened for TB disease and TB infection. TB infection is latent TB. We have treated 5,000 some during the mass screening in Majuro. In the other island, although SIDRIP, we also treat the TB infection. They have also LDBI, and they were treated. Those under some cases about island level, I just discontinued the treatment for after completing 3-month treatment on 3HP or latent TB treatment. Okay? Then number 4, clinicians need to be adjust TB treatment in person with diabetes. It's quite challenging in treating TB with diabetes because most of them, they are prone to the side effect, and also they have a prolonged treatment as compared to the regular TB cases. Okay? And when they develop the adverse reaction, that's another challenge for me to approach or treat them accordingly. And standard 5 is use your TB clinic visit to help person manage their diabetes. Anyway, as soon as a TB patient is completing the treatment, we send back to our NCD to regularly follow up on their diabetes control. And last, we do a TAT. Our nurse and chow do a TAT, direct observation therapy, to our TB patient and diabetes patient. In that way, we know that the good compliant adherent is applied as always. And that's why we got always a success rate of treatment because of the TAT. Well, not much, but those were the plan to go to other island. We finish island level up in Japan. Our will be next month, and Monolap and the rest probably next year. The tool we use, we got the boat, that's the boat over there, and we got the digital X-ray camera. And now there is a new one, very small one. We can put it in your backpack and go to house. And of course, we do a gene expert on the spot. There are 3 phases. Phase number 1, the PPT group go there, screen all the population, and then followed by the main group that will do the mass screening in 2-week time. And then when we finish and find the case, both active TB and latent TB, we send the south to actually do the TAT in other island. We have 2 chow in the island level up, along with 4 assistants. They are doing active TB treatment and latent TB, as I said, they are done. So I'm not going to read all this island from island level up, but that's what we've been doing for the previous 3-4 island is to follow up. So at the end of December or early January, all these patients who are active in island level will be fully treated. And then in March of 2024, those with the diabetes 25 will be completing their treatment. The last slide is some success. As I mentioned, the boat really helped us a lot. It's a lifesaver boat. Okay? Chow, they are over there doing the TAT, direct observation, standardized protocol, birds, NCD, and TB. And of course, continue to do neighboring island TB screening. There are plenty challenge. Staffing, as mentioned by Dr. Kyle, he need more staff. What about me? I also need more staff to do that, okay? Straighten the guideline and share it with the other clinician. Sorry, this is supposed to, geographic challenge, disease. And of course, some of the recommendations are more staff to be hired, screen all diabetes or having TB, And latent TB treatment that was given to the previous LTBI case who are having diabetes. The new recommendation for WHO is do another latent TB in 5-year period or more than 5. Okay? 2 more training to bridge the gap. We need more training and we need more staff. Thank you. These are the people I need to acknowledge. And of course, the donor, the partner, WHO, UNDP, Global Fund, CDC, and the rest. Welcome to Majuro. Thank you.
Thank you, Dr. Zach. At this time, it's time for our panel discussion, questioning and answer or recommendations, any additions. It is now open for the floor.
Yakwe, this is just a feedback to the doctor from Taiwan, the surgeon, plastic surgeon.
Dr. Chang.
Dr. Chang.
Yes.
Dr. Chang, if you are listening, I'm Tavaita. I can still remember you. I believe you taught me how to do debridement of the callus. For those of us who don't know callus, it's a thickening of the skin around the wound. And I believe you left behind some of your fast pixen ointment. And for me, while I've been working at wound care, we have trialed, I have trialed 2 patients.
Sorry, the plastic surgeon, he's not online.
Okay,
Yeah.
sorry.
Yeah, because he's seeing patient. Clinic now. Sorry.
Okay, it worked, Dr. Madison. 2 patients. We've trialed them on their fast pixen. It really heals the wound faster. It has been approved by FDA, and for those of us who are going out in the field, can encourage, empower our patients living with diabetes with little wounds, they still can come to wound care. And I hope that Dr. Madison will hire more nurses for wound care. Otherwise, many will go burn out. So that's for the first pixen. If anyone of us has been not aware of that, I believe here in Majuro Hospital, we've been using triple antibiotic ointment. And remember that not all the wounds are same. Not all the wound needs triple antibiotic ointment. It needs assessment by us, the food care nurses and doctors, the surgeons, and then we'll approve which ointment to apply on all those wounds. If the doctor from Taiwan can do miracles like that, we also in Marshall Island can do the same. But early detection is very important. Amen? So yes, it has worked, that fast pixen ointment. Marshall Island is the first Pacific island to use that. It hasn't gone out in Fiji. But I'm proud here in Marshall Island it worked on their wounds. Thank you.
Any other questions, comments? Go ahead, Dr. Madison.
Good afternoon, everyone. This is just a comment. I didn't hear the other presentation, but I heard Dr. Zach's presentation, and I totally agreed that as long as our diabetics are uncontrolled, you will see more TB cases. And yesterday we did discuss what other steps that we can help. Especially a lot of our patients don't come for appointments. They don't come in because they don't have the $5. So we've actually met today, and because if you don't control the diabetes, all the diabetics in the community, guess where they will end up? Either at emergency room, ICU, referral, hemodialysis, and these are all costly. So I think putting a lot of effort on controlling the diabetes in the community can be done. So those that are going to be doing zone NCD clinics, doing outreaches, you can actually get medication at no cost, and we don't need to charge patients. So if you're going to do clinics and either doing not in the dispensaries because they have the medications, but if you're going to do in the zones or you're doing a clinic without walls, you can actually get medication with you, and then you can issue out for those that have ran out of medicines, or if you want to prescribe. Just want to bring that up. Thank you.
Thank you for the comments. Anyone else?
Thank you, Dr. Madison, for those assuring words, enlightening ones. This will go to Mr. Tanner from Wellness. I'm really thrilled with your presentation stating that we'll have the kiosks at K&K and Payless. Are they here now? Or?
So right now, just one of them is on island. One will be here next month at the latest.
Oh, yes. And as we stated, people will go, they'll do the self-test and everything, and it's the health workers, we have to be ready to receive them in the hospital. So we have to put on our seatbelts when they start flowing in. Since this is one way, they'll go for their self-test, and they'll come to us to the hospital. I'm really thankful that we are getting those kiosks in place at in the supermarkets. Thank you. But we have one at the wellness. You are more than welcome to go there to the wellness. In there, you will put your email as well. Every data will be captured and be sent to your email. Thank you.
Thank you. Anyone else? Yes, go ahead.
Tasting. Good. I just want to impress all the comprehensive topics and presentation that from the beginning. And when it comes, just my opinion, I want to echo what Dr. Madison said and the other. When it comes to diabetes, yes, we are free to eat whatever food we want to eat, but once we have pre-diabetes or diabetes, not all food are good for consume. So we have to take care of our body and choose the LDH food that needed to be consume in order to reduce the amount of diabetes our body have at the moment. So with that, comportada.
Thank you. Any more questions or comments? Okay. Thank you, presenters. Thank you very much. Now we will all break out into group discussion. So we will have 4 groups. If we have our NCD policies. Okay, I'll yeah, so we will have our NCD policies, maternal child health, mental health, and NCDs, as well as NCD clinical services and rehab, and agriculture and nutrition. But before we break out into sessions, we will have a short break right now. four, as I mentioned. The first one will be NCD policies. Then we have here in the middle, we have where Nikki is holding it, that'll be the first group. And then we'll have the second table, we have maternal child health, mental health, and NCD. Okay? So the middle table will be maternal child health, mental health, and NCD. So this will be the second group. The next table we have here on the far left, we have, I'm sorry, I can't see that. Okay, NCD clinical services and rehabilitation. That will be the third group. Then the fourth group, I believe, where is our sign? At the back? Okay, so the fourth one will be agriculture and nutrition. So what I want, if you guys can all participate, go to these four tables, and then have you guys, I want you guys to discuss on healthcare gaps, recommendation, and way forwards. And from the discussion, the group discussion, I want one presenter to come forward and then discuss or share to us what you guys have all come up with. So you guys talk about the healthcare gaps, recommendation, and way forwards. If we can try to make sure that all the groups are, there's participants in every group, okay? NCD policies is here in the front, here with Dr. Zach. Come on, Olive. We'll give you a few minutes for group discussion, and please pick one presenter from each group to come up and share what you guys have discussed. Okay, so the questions that you guys will try to answer is healthcare gaps, recommendations, and way forwards. Okay, thank you. Okay, we'll have 2 more minutes, so please select your presenter to come forward. Okay, Yagoyalab, are we ready? Okay, so we're going to start with the first group. May I call upon NCD policies? Please come forward. Thank you, Dr. Kyle.
So for NCD policies, we saw that there are many policies that have been put in place. Well, not really put in place because they need to be endorsed. So I think that one of the biggest gaps was endorsing these, especially through the national government, in order to make them a policy. And for policies that have already been put in place, I think enforcement was one of the biggest gaps we also saw and a lot of people talked about. And I think another gap is financial funding for these in order to enforce or in order to put these policies in place. I think that's it.
Thank you, Dr. Kyle. Next, may I call the next group? Let me see. Maternal, child health, mental health, and NCD. Please come forward.
How is this maternal health?
đã khỏe, tại anh cài à?
Yeah, wait, what? This is our team, maternal child health, and mental health in city. So,
We heard yesterday about NCD Master.
Sorry, I'm very nervous.
We are here, I'm holding you.
To reduce the gap, we need special need for MCH.
And there is one-stop shop.
Yeah, and there's the one stop shop for
One-stop shop.
one-stop shop for NCD.
And
For
also for maternal.
yeah, and for maternal shop. And I will give to Taina to elaborate more.
Thank you, Nelson. Yeah, it's on maternal child health, mental health, and NCDs. When we talk about that, it's the three, but one main aspect is missing, the mental health. And we heard about one-stop shop, that's NCDs. Great, it's running. And we want a one-stop shop for maternal child health. We're gonna make it happen. But with that comes mental health. It's a key point here. Without mental health, there's no? Yes. And then, because it's just a short time, we just want to emphasize on the mental health. When you go out there, wherever, whichever clinic, I heard over from yesterday, spend more time, not 3 minutes, more time. And this one thing that we capture, where we try to eradicate this NCD or lessen, how about our workforce? Do they all come from medical clearance? Big question mark. Shall we make it happen? We recommend that. And that's where we're going to bring our workforce. We want you to be healthy in order to look after RMI community. So medical clearance, not only for those who come for food handler, not only for those who come for medical clearance, everyone, when you go on leave, come back, have a medical clearance before you go and start again. Maternal child health, as you can see our setup, most of the mothers go around the corner to family planning. That's why we wanted a one-stop shop. We don't lose them. All right, I think so. We have only a few minutes. And that's about all from us. Thank you.
Thank you very much, Maternal Child Health, Mental Health, and NCD Group. The next group I'd like to call is Agriculture and Nutrition.
Okay, Yakwe Howlip. Okay, agriculture and nutrition. First, we would like to see what's in place so far. Right now, we have the Heart Healthy campaign and pre-diabetes program. Under Heart Healthy campaign, we're going to purchase 2 blood pressure kiosks, stations at the KNK and Payless. How about that? And then our island hypertension reduction campaign to Chalui, everyone in Wetye. So we need to include all other islands, neighboring islands. And under pre-diabetes program, on Medjero, over 50 people enrolled already, which is good. We need more people. There are like 25 plus people in Medjero alone. For lifestyle coaches, and to expand to the other islands with Zoom conferencing setups on everyone, Chalui and Wetye. But of course, we would like to do it for other islands. Oh, okay. Continue.
Okay, thank you. And our recommendations are, first of all, the hospital has to hire a dietitian and a nutritionist. And all schools to encourage gardening. That is, all schools can be encouraged to have gardening competition and be awarded at the end of the year. And agriculture schools or programs to be introduced in the school curriculum. And more community-based training on food preparations. The next one is all government ministries to enforce a wellness and gardening day. That is where we can have a panel, and that all the ministries under the RMI government can always have a gardening day or a wellness day. Okay? And also to encourage local and Marshallese made products by supporting outer islands and help them produce more local product, and people in the main centers like Majuro to be encouraged to buy these local products. Thank you.
Thank you, Team Agriculture and Nutrition. And last but not the least, I'd like to call NCD Clinical Services and Rehabilitation.
Yakwe Alep. Okay, we have a lot of list. we have a lot of lot of points to highlight on the care gaps, to improve the services in the community for non-communicable diseases. It is important for us to let you all know that there are a lot of gaps from our observation from the past 3 months we have seen during the community profiling. One is health education and awareness. We need to increase, we will say our list together with the recommendations. For education and awareness, we need ongoing mass media awareness on all conditions, all NCD and CD's problems that we have here in RMI. And increasing community awareness in the churches, schools, and not only that, but also at the MCH clinic, maternal child health. Not only from that, but from the maternity unit during deliveries. After delivery, at postnatal, mom need to be educated on exclusive breastfeeding. That's the only way we can help our future generations from preventing them from having NCDs. So it starts also from prenatal. Mom need to advise on the food they need to eat during pregnancy because it affects the baby. Because if they start eating sweet foods during pregnancy, this child know the taste of the food already from the womb. So health education and awareness is important. And also another one is screening and early detection. I believe screening, we don't go out to the community and screen only for the existing conditions, but we screen for the new cases. Early detection is very important. We enhance access to screening services for NCD, such as diabetes and hypertension, cardiovascular diseases, and also for kidney. I believe we have a lot of people living with diabetes are already having kidney failures. We can prevent that, but we need to be educated, the nurses, the healthcare workers, on how to detect mild kidney problems so that we can guide this person towards a better future instead of coming into the hospital with end stage. And another one is the primary healthcare integration. We need to integrate everyone in the Ministry of Health, mental health, family planning, reproductive health. We need to work together. in order to prevent NCD in our island. And all our new healthcare workers need to be trained, especially the new graduates. So when they are coming into the field, they already know what to do. That's for primary healthcare integration. Training primary healthcare providers on NCD diagnosis by having maybe some frameworks or management guidelines. We need to know the management guidelines on diabetes, hypertension, all of kind, cardiovascular, kidney, so that when we go out, we know what to do and where to direct our patients to. And another one is patient-centered care. Promote patient-centered care by improving communication and coordination among healthcare providers, the patients themselves, and their families. One thing we found out that when we are going out in the community, most of the family members don't know that their chima, their boo-boo is having diabetes or hypertension. When they come to the hospital, it's very important that the doctors or general practitioners or practitioners or nursing practitioners need to ask the patients to next visit to bring in their family members who can help them, guide them out when they are in the community or in terms of monitoring. And another thing is the access to medications. Access to medication, some of the patients, they don't come to hospital because of the transportation. $1.50 they cannot afford, and it's like $3 and plus $5 for the fee to be coming to hospital to access our services. So it's very important that we need to ensure the availability and the affordability of the essential medication to manage NCDs. And these can be accessible to our zone nurses, and for those of us who are going out in the field, we need to access to these essential medications, especially for those who are having hypertension and also diabetes. We need to work closely with pharmaceutical services, the companies, the policymakers who are here in front of us. Please, we need free accessibility or free medicine scheme for our patients living with NCDs. And also, we need to improve the supply chains of medications. I believe most of the time, pharmacies, we don't have essential medication. It's run out or stock out. Therefore, people living with diabetes or on NCDs are not taking their medication. Even though they're coming to hospital, they paid their $5, they paid their $1.50, but there is no medication. We need an ongoing supply of medications to the hospital. They may be doing their part, they're coming to the hospital, but they are no medication. And we are strongly educating them, you need to take your medication, but there is no medication. And establish mechanism of subsidizing, I believe that is in the process right now, according to our Director of Public Health. And another thing is the manpower. I believe we have highlighted that during in the morning. We need to have a lot of healthcare workers out there in public health level. We've seen a lot of staffs in the curative, but there are less people in the preventative. So we need a balance of manpower, but we need more manpower in the primary health, public health level, because we should be more on preventative, not on curative. And another one is the lifestyle interventions. Implement community-based programs that promote healthy lifestyles for us who are going out for screening of all kind, mental health or anything, NCDs. We need to present back to the community, to the ALAPs or to churches, the screening results. It works. People are taking action after we presented our data back to them. They take action. Because if we just go and screen them and come back, we don't provide them with any feedback, you think they will do anything? Never. I've done that already two times, but they are doing something out there. And yes, for the lifestyle programs, and it needs to be monitored. We need to ensure that they are having regular physical activity, healthy diets, smoking cessations. Smoking cessations will only take place if the policy is implemented. And for smoking cessation, as I've mentioned already for the past few days, we need committees to monitor the compliance of these policies. Unless if we have committees, then they will be able, people will be aware that there are policy of tobacco here, so please, we don't smoke here. But, I mean, also, in addition to that, we need a smoking spree and label. That's a smoking spree, you need to go and smoke there, but they will say, okay, where should I go and smoke? Unless people will see there is a smoking spree, then they will go to that smoking spree to smoke. If they don't have any smoking spree anywhere, they will just smoke in front of that smoke-free place. And another one is psychosocial support, where mental health comes in. We recognize the psychosocial impacts of NCDs. All people living with NCDs, they need psychosocial support. And we cannot get hold of Yobi or Dr. Olden to come and see 20 patients. That's a lot, and we need everyone to be trained on that. And the other one is data collection and monitoring. We need to develop a robust data collection. All the departments, we need to be upgraded with our data collected from the community and needs to be presented to maybe to a national level where they will hear us, and maybe they will support us with whatever plans we have in our departments. And because those data is an evidence base of what we are doing, I think that is what we are lacking in, the data or reporting, sorry. Okay, almost there. And yes, we already highlighted about the policy. Unless if my team has anything else to say, I will give them the mic.
Okay, just one add on. Based on the presentations we've heard them from yesterday to now, we can have all those things that we've been presented. We are trying to find ways to make it improve of our health services. But as long as healthy lifestyle, diet should come in first, because we cannot treat patients with medications all the time. We need to control our diabetic or other NCDs without diet. Here in Majuro, I'm from outer islands. I cannot grow food near my house. It's a small space. When I go to the store and buy food, really expensive. They're the most expensive food on island are the healthy food. So for the policy makers, if they can just reduce the amount of the cost of the diet, the food that we grow, then it can be a contribution to the healthiness of the people. That's all.
Thank you.
Presenters, can I give you your prizes?
Yeah, just. Okay, all the presenters, would you please come to the forward? Now it's an exciting game. The presenter will get the raffle. Which team
Thank you, everyone, for your participation. I'd now like to give this time to our Minister of Health, Secretary Francine Wase Chaklik, for closing remarks.
Kumoltada, Dr. Jean. Yago yung ano ulit, yung Romy Ray Barcoba, dakulo Zoom, yung Kochat. Just wanted to just give a vote of thanks and acknowledge the presence of our Vice Superintendent for coming all the way from Taiwan to spend his time with us this week, for looking at our profiling team and all of the programs that we've developed thus far. Chamorang ilala chon kapobongan eh. Shishay. And also to our Taiwan nephrologist, Dr. Chen? Yeah. Thank you so much for coming. Once again, he's been coming for so many years, and hopefully he will continue to come and support us. And also our new friend, he's a doctor for children. He started doing his work last week. The first day, he said, oh, it's okay, it's not too busy, but the third and fourth day, he said, okay, now I'm feeling the feeling the heat. So to our pediatrician, Sheshe, come on. You'll be here for 3 more weeks. So for those that are wanting to bring their kids for a wellness baby check, this is your time to see him. And especially to everyone that has come from all different departments, it's very refreshing to see everyone come together to just trying to look at the NCD plan. And I'm sure from the outcomes from today's meeting, we are ready to move forward with the validation and the collaborative efforts of the outcomes of the past 2 days meeting. So on behalf of the minister and myself and the entire leadership, we thank you for your dedication, your support, and your excellence. So, komoltada. I would like to acknowledge our MC for the entire 2 days. You could be like Taina, General Assembly official MC, and you'll be an official MC for big events. And I also want to recognize the MLT team for ensuring that these 2 days come into fruition and ensure that we're all here to work together. And last but not the least, the coordinating committee. Can we give them a round of applause? Nikki, Myung, Tavaita, Chief Nurse Elia, Marline in the back, Leilani, and everyone else that have really put together this event to be a successful event. Thank you so much. To the presenters that were here, thank you so much. All of the presentations that were shared were very enlightening and very important for this year's summit. For our international presenters, we acknowledge Dr. Sai and the team from SPC. And we also acknowledge the regrets from WHO due to medical conditions of the presenters. They weren't able to join us this year, but we do acknowledge that they were supposed to join us. And we look forward to the future of this event, if there should be, and the Taiwan government for their endless support. I think I've said everything, but if not, komoltada, sheshe, salamat po, vinaka, wahaini, komol, komoltada.
Thank you, Secretary Francine. I'd now like to give this time to Vice Superintendent Dr. Chen Chi Hua for our closing remarks.
Thank you. Secretary Francine, distinguished guests and all attendees, ladies and gentlemen, good afternoon. It's both an honor and a pleasure to stand before you today on behalf of Taipei Medical University Shuanghe Hospital at the closing ceremony of the 2023 NCD conference. I'm very happy to see so many friends gather here today, as well as those who joined us yesterday. Taiwan has come a long way since the 1950s when we were recipients of foreign aid. Today, our health system stands as one of the best globally, providing our citizens with exceptional medical service. It's with a great pride that we share our achievement with you at this conference, and we also view this as an opportunity to learn from your experience. The challenges of communicable and the NCD, as well as the maternal and the child health, continue to be at the front from global health concerns. These challenges are central to our transition from the Millennium Development Goals to the Sustainable Development Goals, SDS. As responsible global citizens, Taiwan is committed to doing our part, strengthening health system, leads to better care service, involving all facets of government, address all dimensions of a problem, and the comprehensive actions is the most effective way to safeguard against disease of all kinds. Addressing NCDs is not only crucial for global public health, but also beneficial for the economy, the environment, and the broader global well-being. By uniting to combat NCDs, we can do more than heal individuals. We can secure our collective future. Over the past 2 days, I want to express our gratitude to all of you for sharing your wisdom and your wisdom and the knowledge. This conference has served as the stark reminders of the urgent needs for accelerated action to protect both current and the future generations from NCDs and their causes, including food drinks high in salt, sugar, and fat. We have also highlighted the importance of addressing mental health issues. In closing, I will extend my heartfelt thanks to all of you for contributing to the success of this conference, bringing together the collective knowledge and the experience of everyone here, demonstrated our unwavering commitment to combating non-NCDs. Today, I would like to take a moment to express our gratitude once more to the RMI, Ministry of Health and Human Service, and the Taiwan Ministry of Health and Welfare. They have supported Taipei Medical University Shuanghe Hospital with the opportunity to lead the Taiwan Health Center project. Over the past 10 years, we have diligently carried out our mission in the Marshall Islands, realized the vision of cross-border cooperation and fostering strong camaraderie. In conclusion, thank you once again for your kind attention. I hope that all of us leave this conference with expanded horizons and a deepened understanding of the issue at hand. Thank you. Komo tata.
Thank you, Dr. Chen Chiwa. To conclude our 2023 Non-Communicable Disease Conference, may I now call upon our MOH chaplain, Reverend Piwich John, to please give us a closing prayer.
Moldada MC, Jochar. Ginamgar Kuba Perron, Loranagin Ro, Ami Roach, Mamanich Kimich Kaudijum Kamulu. Kama Rekal, Ipiam and Uchon, Rukaleo, Ijichut, Kama Lewe Menodum Raman. Irila Oleben program Kama Kuba Pendron, Kugar Peram Sander, Menodum Jich. Abam Kamuluk and collaboration again, and ministering. Taiwan el sander all even rin me ala bijo kunai riur malok cerobali nejimur bencuan push priority ngan kemilo ailing ki perjuangan ko molgan ale participant rin molgan ale presenter ko molgan ale rin udum ji rar ko bay pendron ngan kamman boy yenigin ramman mala badada en urchuan kada ga marpugi ki yegem pojen chepalak ngaichar aje waj kachuju ya le dongan kem langleng kamman Rada kamar bo kemin apply ki oleh mirigin kemara kada kagi kemin cepat pugi bot ligdi piam kemin cherry ledo leda kemelegin an haram jerin kemin charbalangalir perjuangan katai kem wajoj minodem jich ilodem crisis kumolot amen.
Thank you, everyone, and thank you for your participation as well. Have a blessed weekend. Kumol.